So welcome to our next session, and this is for Derm Talks. Dr. Hafeez Diwan is going to talk to us on diagnostic pitfalls in dermatopathology. And before we start with the lecture, I would like to draw your attention to the 36th ISDP symposium in India, and I already mentioned a couple of these sessions. If you have time, this will be an absolutely great event, and please try to attend. And I'm going to give Hafeez now Dr. Diwan the control. I sent you the control. If you can click on it, and then we will be able to see your screen.
Can you see my screen?
Yes, thank you, John. Thank you very much, John, for joining, and greatly appreciate that. So I see it, and I think that everything is perfect. I will moderate the session. So if anyone has questions, then please use the chat window, and we will have a questions and answer event at the end of the talk. We will have about 45 minutes, 50 minutes for the talk. And I would like to give an introduction to Dr. Hafeez Diwan, who is a superb dermatopathology. He did his fellowship at University of Alabama, and then he was faculty at MD Anderson for 7 years. And actually, that's where I met him in 2008, I believe. And then he went on to the Baylor College of Medicine for the last 6 years, and he's there the director of dermatopathology. And his interest is in pitfalls and errors in diagnostic dermatopathology and strategies to avoid them. One personal note on this for the introduction, that as I told you, I met him in MD Anderson, and he was a very memorable interviewer for him, because he was extremely pleasant, extremely at the same time smart person who had a fantastic sense of humor. And whenever you see lectures from him, I think that this braininess of him is shining through these presentations, and I'm extremely ecstatic to have him on this program, because he's not only going to talk to us about diagnostic and psychological factors in dermatopathology, but this, I think, will be also a teaching session how to put together an engaging and entertaining PowerPoint presentation that we are looking very much forward to. So with all that, thank you so much again for accepting our invitation, and we are extremely excited about your talk.
Well, thank you, Laszlo. I really appreciate this, and thank you for all those nice things. I sincerely hope your online audience doesn't want to take issue with you after I finish with the talk, you know. But
You started already, it seems.
I was gonna ask you. You know, I'm seeing this thing on the side, GoToMeeting control panel. It's not. I mean, your viewers. I mean, is there any way for me to minimize that, because
Yeah, you
I'm
can. You can. I think click on the orange button, or just push it out of your site to the side. We
Oh
don't.
yeah, I pushed it out of my site. That worked.
Great.
Okay. So so anyway, thank you very much again for inviting me. I'm going to be. Some of you may have heard a portion of this talk, a significant portion of this talk, if you were at the ASTP meeting, because I presented portions of this talk in that meeting. I'm going to be talking about things that I have learned, things that I have found useful. You could call it diagnostic and psychological factors in dermatopathology, or psycho dermatopathology. Uh, you know, not that we are psychos, but you know, we are human beings, and so the psychology of the way we think has a great bearing on how we diagnose our cases. So um, this is my email address for those of you who send me complaints afterwards. But what lessons am I talking about? Nothing really earth-shaking, okay? I have divided into 5 portions, 5 sections. Bottom seeking, getting the necessary clinical information, help from the puffy shirt, the joys of sadness, and accepting that you're a human being first and a pathologist later, and that is very important. What do I mean by bottom seeking? It means that we are seeking the bottom of the lesion because it may be different from the top of the lesion. I was looking for a metaphor for what for the bottom, and in our culture in the U.S., not in my culture, because in my culture the moon is usually a beautiful thing, but here in the U.S., when you say you're going to moon someone, it implies that you're going to unveil your bottom. And so I think it is important in this context that I'm talking about the moon as the bottom. And and here you can see this is a famous scene from the film E.T. And this guy almost looks like he's a pathologist, right? And this looks like his microscope, doesn't it? So there's your dermatopathologist, and he looks like a microscope, and that's what we were doing really. We're trying to seek the bottom in this first series of cases that I'm going to show you. So sometimes the bottoms are very sneaky or small. They are barely visible on the slide. Here is an example. There's a 46-year-old male from Ghana who had a beefy red tumor on his left toe, and the question was, is this an infection? So this is what it looks like, and it looks like a pyogenic granuloma. It's got a nice color red, it's got the ulcerated granulation tissue, and it really, it looks like it could be just a PG, like a pyogenic granuloma. This is what it looks like. You've got the nice vessels over here, inflammation, but this area here, okay, looks a little different, okay, and here is an HHV8, which is positive in that portion. What you were seeing on the top was just the incidental granulation tissue, which had formed a PG-like structure. But what really this case is that of a Kaposi sarcoma, which was only at the very, very bottom. And in this case, at least you had a bottom. It just wasn't very impressive. So if this area had not been noticed, then the diagnosis would have been missed. William Shakespeare had something to say about this. He, in his play Macbeth, Lady Macbeth, is advising her husband to look like the innocent flower, but be the serpent under it. And I believe this is something they teach you in politician school. If any of you are thinking of running for office, this is something you might have to do in your life. But sometimes lesions do that. So this is the innocent flower on the top, the pyogenic granuloma-like portion, and this is the serpent under it, the actual Kaposi sarcoma, the lesion that was hiding. Let's look at some lymphoid bottoms. Let's consider the example of a 79-year-old male who had lesions removed from his left outer canthus and left flank in 2009 and 2011. And then in 2014, he had a left back lesion. So this is what it looks like, okay? You've got low power view showing proliferation of lymphocytes. It's wedge-shaped, it's top-heavy, okay? And let's look at this area here. And you can see plasma cells in this area. And here is an immunohistochemical study. These are all kappa positive and totally lambda negative. So what you have is the monoclonality present only in the lowest portion of this lesion. It was not there in the upper portion. So if you had a biopsy that was only this much, you would not have seen it. But you can see this here because when we stain it with the kappa and lambda, the monoclonality becomes clear, but only in the lowest portion of this lesion. I have some other examples of this phenomenon. There's a 66-year-old female with a neck lesion. The question mark was this a cyst? So what we see is a dense lymphoid infiltrate. So again, you have this very dense lymphoid infiltrate, and we'll focus on this area here. Again, you see lots of plasma cells. Let's look at the kappa in the upper portion. In the upper portion, you can see that the kappa and lambda are about equivalent. But in the lower portion, actually the absolutely bottomest portion of this lesion, you have very few kappa, and it's really lambda predominant. So this is another example of a marginal zone lymphoma, only evident in the lowest portion of the lesion. Here's another example of a case. Okay, this area here is highlighted in this panel here, and you can see that this is BCL2 positive, CD20 positive, and then you can see that in the upper portion there's virtually no difference between the kappa and the lambda, but in this portion here, in the lowest portion of the lesion, you've got a kappa predominance. So you have a few lesions, 3 lesions that I've shown you. There are 3 lesions that I've had over a period of maybe 3 years. So it's not very common, But my practice has been that if I see a cutaneous lymphoid hyperplasia and it is not completely excised, then I usually mention that it is not completely excised, and then there's no harm in just going back and taking it out. You might have come across or might have heard that there have been some cases of cutaneous lymphoid hyperplasia in the literature that went on to transform, and I'm using quotation marks, but you can't see me do that, in quotes, went on to develop lymphomas. Now, is it possible that they were lymphomas to begin with, that the entire lesion had not been analyzed? So I think that it is kind of important that even something which is a straightforward cutaneous lymphoid hyperplasia, it is important to make sure that you see all of it. And if you don't see all of it, to mention in the report that you don't see all of it. Marginal zone lymphomas generally do not do that badly, but they are not completely harmless lesions. And so I think it is important to get the diagnosis right. But now, in the two examples I've shown you are those where you saw the bottoms. They were just very deep. What if the bottom is absent? You're just not seeing it. I think that's way more tricky than where you have a bottom, where you actually have the bottom present. So let's look at a few examples. An 80-year-old male who had a left arm lesion that was removed on November the 30th in 2012, and this is what it looks like. It just looks like a plain, nothing, no problem with it. This looks like a poroma. Okay, you've got the poroid cells, the ducts. Okay, nothing very remarkable about it. You know, now 2 months later, this lesion was re-excised. Okay, so here is a thing which looks like the poroma on the top. Okay, here is the scar. Okay, this is the poroma. It looks exactly like the poroma you saw previously. And here is the scar. And let's look below the scar. So below the scar, you have an infiltrating process, and it looks a little different than the one that you saw above. And here it is. It's got an infiltrative border. You can see it here. Here it's infiltrating into the tissue. And so this actually is a porocarcinoma or an infiltrating adnexal carcinoma of some kind, which is arising in this lesion, which maybe this lesion was all along. It was just not visible to us in the initial biopsy, which just showed the poroma portion. So again, this is what it looks like. Okay, this is the portion that we saw in the beginning, which was the poroma, and this is the infiltrating adnexal carcinoma. So this is the original poroma area with the scar, which again is the innocent flower, as William Shakespeare, if he was signing out reports, he would say, "This doth show an innocent flower on the top," blah, blah. But the bottom is the infiltrating adnexal carcinoma, or the serpent under it. Let's look at another lesion. An 87-year-old with a forehead lesion, August 2012. So this looks like a sebaceous adenoma, and there is nothing really remarkable about it. It's except for the fact that it is right there at the ink. You can see that it's touching the ink, but honestly, this just looks like a sebaceous adenoma. There's nothing, no bells, no whistles to it. Okay, that's all it looks like. But nearly a year and a half later, there was a nodule in the same area where this thing had been biopsied. So it was rebiopsied at this time. So here you have the scar, and you can start seeing something over here. And those of you who are Creedence Clearwater Revival fans might recognize this song. I see a bad moon arising, and this is the bad moon. This is bottom, which is arising right here, and it even looks like a moon actually. It's very atypical, as you can see. See, these are markedly atypical cells. They are very different from the cells that you saw before. Here, they're obviously sebaceous. There's no question about that, but they are very atypical. So again, this was the innocent flower, and this is the serpent under it. So, of course, now we're not going to tell our clinicians that, oh, this is a sebaceous adenoma and you better go and re-excise it. But I do let them know that it's going to the base of the biopsy, and then alert them to that possibility that that things like this can happen. Now, my goals when signing out are try to be as accurate as possible, of course, and be a sheep. And by a sheep, I mean that do what everybody else does in that situation. Because remember, when we get sued, if we get sued, and I hope we never get sued, The important thing is that did we do everything that we could possibly do that any reasonable pathologist would have done? And if we can demonstrate our sheepiness to the court, then we cannot be faulted. So we have to be able to prove to the jury and to the court, to their satisfaction, that we did everything that we could that needed to be done. So now so how do we become a sheep? First, you do everything that we need to make a diagnosis, and this is what I call the pre-bar strategies. And the bar, of course, refers to the sound that the sheep makes. Those of you who have children or who have seen sheep, who have been on farms, you know that the bar is the sound the sheep makes. So the pre-bar strategies are to collect everything that you need to have, like all your sections, all your stains, everything, show it to people and so forth, and then give the diagnosis, which is the bar strategy, actual making the diagnosis. So the pre-bar strategies include correlating with the clinical, if it is available, okay? And please use the telephone. Just call somebody. Call your clinician, email him or her, and find out some information about the case. Now, let me show you some examples of what I mean. Here is a 38-year-old man with a right arm lesion, okay? Actually, I'm sorry, this is a 38-year-old female with a right arm lesion. And this is something I called squamous cell carcinoma, okay, and it looks very atypical, okay. These look like very atypical keratinocytes to me, with keratin pearls, and I thought that what I was dealing with was squamous cell carcinoma. Here are the keratin pearls, okay, more of the same lesion, okay. But then I got a surprising phone call, okay. And while we're on the subject of the phone calls, I'm going to share some scenes with you from a film called Dial M for Murder, okay? This is an actor, a very fine actor called Ray Milland, and he is very upset because his wife has been unfaithful to him, and he has come up with this brilliant plan to get rid of his wife. And this is obviously, I'm not condoning his behavior, I'm just trying to make a point here. So his plan was to call his wife, okay, and his wife would then come to the phone and answer the phone. And he's blackmailing his old school friend, and he has told her that he has to go and stand there behind the curtains. And when his wife comes to answer the phone, his job is to strangle the wife. Of course, there'll be no suspicion on the husband because he's miles away at his club. All he has done is to place a phone call. Now, this is Grace Kelly, and while she has holding the phone, he's holding a pair of stockings here. But note the fact that while he is holding the stocking, it is absolutely impossible for him to strangle her while she's holding the phone. I mean, this is strangling 101. I mean, I know I don't have to tell any of you not to strangle, but if you were to strangle somebody, and I sincerely would advise against it, then the neck has to be clean in your grasp. You can't have an arm sticking up. And the point of the story is that while she's holding the phone, she is safe. The moment she puts the phone down, he gets on with his business. And the moral of this image is that pick up the phone, call the clinician, figure out what's going on. And in this instance, I had made an incorrect diagnosis of a squamous cell carcinoma because what the clinician told me was that this lady was fleeing from her captors in the Ecuadorian jungle, and she escaped into Texas eventually. But while she was escaping, she was bitten by a fly or some insect of some kind. And what happened to her was that she developed leishmaniasis, and that's what this was. This was leishmania, and you can see the leishmania quite clearly, I think, in these images, And this is something which I had just not been aware of or had not noticed before I received that phone call, which is why I made the wrong diagnosis, the incorrect diagnosis of a squamous cell carcinoma. So this was actually leishmaniasis pretending to be a squamous cell carcinoma, and the way I was clued into it was by the phone call that I received. Let's look at another example, a 43-year-old female with a stat biopsy. Okay, this lady was at our county hospital. They did a biopsy on her leg, and then they sent it. And this is what it looks like. Okay, here is the biopsy, and here are what appeared to me to be fungal organisms. Okay, they look like fungal organisms. Okay, right here. Uh, I mean, I think it's very hard to ignore the fact that these look like fungal organisms. I showed it to several very good dermatopathologists, okay, and everybody agreed with me. Oh yeah, this has got to be something fungal. So and here you've got, it's even branching over here, as you can see. So I called the clinician and said, oh, this lady has a deep fungal has a fungal infection, And he says, are you sure? And I said, well, it looks like it. And she says, well, but she looks fine to me. I mean, she's just sitting in the clinic right now, and I did a biopsy because I'm concerned about nephrogenic systemic fibrosis, because she's got like the woody induration of her legs. She has the typical history of nephrogenic systemic fibrosis. She has renal failure. She received the contrast imaging studies and so forth, and that's what she has. She doesn't look at all in any kind of distress other than the fact that she's got nephrogenic systemic fibrosis. So I took another look at the case, and indeed, this was nephrogenic systemic fibrosis. These are elastin fibers, and this is the classic lollipop lesion which they describe in nephrogenic systemic fibrosis. You can see the elastin fiber, which is piercing this sclerotic body. So this is actually an example of nephrogenic systemic fibrosis, which just looks a lot like a fungal infection. And again, this was a misdiagnosis that I nearly made. Of course, after I called the clinician, I corrected it and didn't sign it out as that. So these things are known as lollipop lesions, which you might have heard of. So this is basically a sclerotic body which is pierced by this elastin fiber. This is a painting by Picasso, and here's a lollipop, and it looks quite kind of like what I've shown you. Let's move on to the next topic, which is that of a nevoid melanoma. And everybody fears nevoid melanomas, right? Because we are always afraid that we don't want to miss it. So, which brings me to the concept of dermatopathology and suffering. Now this is a scene from one of my favorite movies. It's called North by Northwest. Okay, these two gentlemen here want to kill Cary Grant. Okay, but they're in an elevator, and this lady here is Cary Grant's mother. They decide not to kill him in the presence of his mom and all these other people, because it would be socially awkward. So having your mom around helps. But I've never had my mom sign out with me ever. She wouldn't. We have a great relationship, but we don't sign out together. When mom's not around, see what happens. These same individuals are going to get him drunk and then are going to drive him over the cliff and kill him. Of course, that doesn't happen in the movie, but the point is that sometimes sign out can get rough, and anytime I'm dealing with a weird nevoid lesion or a nevoid lesion, I'm worried it might be melanoma, then I do get a little bit of heartburn. So in this instance, the thing that I have found to be useful is getting help from the puffy shirt, and this is what I mean. Let's look at an example, and I will demonstrate what I mean. 53-year-old female with a pigmented lesion on the neck. This is what it looks like. Okay, it looks like a nevus. I mean, how many lesions like this do we see? And we say that these are just nevi, So this area here looks very nevoid. This is the puffy shirt. Okay, for those of you who are Seinfeld fans or Seinfeld buffs, you might remember this episode where Seinfeld is forced to wear this puffy shirt, and the point behind the puffy shirt is that there's just too much shirt and too little space. I mean, you could make 3 shirts out of the amount of material that is present in this shirt. So it's a lot of shirt crowded in a very small space. And so the puffy shirt appearance is what I refer to when there are too many cells crowded in too little space. Okay, so I use that as a triage method. If it seems very crowded and stuffy and puffy shirt, their appearance, then I start worrying about nevoid melanoma, and I might do additional stains, as I will show you in a minute. So you can see here, you see puffy shirt, puffy shirt. They look like mirror images almost, at least if you make certain allowances. So let's look at this area here, okay? It just seems there are just too many cells. It seems too packed, okay? And then you start looking, you start seeing mitotic figures. I've got my arrow on one mitotic figure here. Here's the same mitotic figure, okay? Mitotic figure, okay? Another mitotic figure there. So you've got mitotic figures. Now, of course, nevi can have mitotic figures, right? It's not that they can't, but when you start seeing these kinds of things, you start to worry. So I did some stains. The same individual, by the way, in another portion of the same specimen that I have shown you, there was an area which looked like this. And here you can see that the nevus sites are spread apart. So it's like they are not crowded together. They're not too many cells in too little space in the puffy shirt configuration. Instead, you've got cells that are spread out. So there's a clear contrast from the other portion of this specimen, which looks very crowded and stuffy. So this is the puffy shirt area, and this is the non-puffy shirt area over here on the left. Here you have the puffy shirt appearance, okay? So here is a double stain. It shows you the brown Ki67 and the purple melanase stain. And you can see that the area which was the nevus has no proliferation. So it's totally innocuous, harmless looking area. In contrast, look at the puffy shirt area, and it has got lots and lots of Ki67 positive cells. So it's even marking like a melanoma. So I call this a nevoid melanoma. It was just a very tricky one. There are others, and you will see others, and they get progressively easier. Like this one, I don't think anybody would have too much of a problem with. You know, the mitotic figures are very easy to find. This one is very it's nevoid, all right, but I think most people would get the diagnosis. And this is actually a puffy shirt. My fellow last year, Justin Harden, he ordered this puffy shirt online, and his wife pinned it up on this nice board, and they framed it and put it inside this nice box. And I hang it in my sign-out room to remind me every day not to miss the puffy shirt appearance. Now, moving on, let's talk a bit about the psychological factors, okay? Particularly the joys of being a bit sad, a bit anxious, and a bit afraid, because all these things will help when we sign out cases. This is a famous researcher, okay, Forgas, and he has written a paper, several papers, and I'll read the names, which kind of give you an idea of what his papers are about, on being happy and gullible, mood effects on skepticism and the detection of deception. Basically, the point of this paper is that if you're in a kind of a happy kind of, everything goes kind of mood, then, you're much more likely to be credulous, much more likely to make mistakes, much more likely to not see through mistakes. It's nice to be happy. I want everybody to be really happy. But when you're signing out, it's good to be just a little bit afraid that you don't miss something. Then he's got another nice paper called "Don't Worry, Be Sad" on the cognitive, motivational, and interpersonal benefits of a negative mood. So I don't want to drive everybody into the depths of depression, despair, and anxiety, but I do think it is helpful to be afraid, just a little afraid, not very afraid like in that movie, There's a film, I think the Blair Witch Project, they said be afraid, be very afraid. I never watched that movie, but I think that line is in there. But don't overdo it, but just be a little bit afraid. Dr. Storbeck is another researcher in this field, and he has written an excellent paper which he's entitled "With Sadness Comes Accuracy: With Happiness, False Memory, Mood and the False Memory Effect." Now this paper, as the name suggests, emphasizes again a similar point, that if you want to be accurate, you have to be a bit on the alert, because when you're happy, you're likely to let go of, to not pay attention to certain details that are important to you. And this is Justin Storbeck. Now, and he's kind of smiling, and he looks way happier than I would have anticipated from the title of his paper, since I think he's advocating sadness. But I'm glad he's happy. Let me tell you about this little story, and it may or may not be true, but I read it in a book. Okay, so it could be true. So there's a tale of an English vampire in India. So there was an English woman. She was addicted to raw meat, and she saw a rickshaw accident. And I don't know how many of you know what a rickshaw is, but it's a kind of a three-wheeled uh, uh, carriage, and it's you see it in several parts of the East, the exotic East. So she was in India, and so she saw this rickshaw accident, and this victim who was bleeding to death on the scene. She just couldn't resist getting a little sip from the blood, and so the lady expired a few days later. Now she was not. Now what the explanation behind this sad and terrible event really is that from childhood, because of some physical disease, she found it absolutely necessary to eat raw meat because she needed that blood. And in the days leading up to the blood drinking rickshaw episode, this poor lady had been especially deprived of her diet of raw meat. And so when she was there at the scene, she just couldn't overcome her desire to have the blood. So that's basically it. And then unfortunately, when she did that, she had the blood, then she suffered the consequences and she died. So now, what does all this have to do with the practice of pathology and the practice of dermpath? And here is the answer: 46. This is the number of chromosomes that we have. So we are all humans, of course, and so we are humans first and pathologists second. And so we have certain characteristics which make us prone to making errors. And now I'm going to address some of those in the remaining portion of my talk. So here is another famous character from Seinfeld, George Costanza, and he has an office romance that leads to his dismissal from the job. And so the point is that office romances are a very bad idea for pathologists, okay? And what kind of romances am I talking about? I'm talking about the diagnosis, romancing the diagnosis. So the worst romance in the dermatopathologist's office is that which we have occasionally with a bad diagnosis. I sometimes have romances with bad diagnoses on an hourly basis. Okay, I really want to call something something, but then I think about it and think better of it. Okay, or you might have a case where you really want to call something, give something a certain diagnosis, and you want to call it, and you feel it is that, but you're wrong, and you have to catch it. And so I'm going to share some ideas with you about how one can prevent oneself from romancing the wrong diagnosis. There's lots of books, there's a lot of literature on this topic. Like, for example, there's this nice title, Why We Make Mistakes, and you can see that the S is facing the other way. Another book called You Are Not So Smart. This is something which I always remind myself of, and whenever I forget, my wife is always there to remind me of it. And here are some methods you can use to not make mistakes. First and foremost is don't be like King Lear. King Lear is a famous character from Shakespeare, and basically his problem was that he surrounded himself with yes men and yes people, and that led to his downfall. The only person who was truthful to him was his daughter, whom he banished from the land, and then, the ending was terrible. Everybody died in the end. It is just a total downer. But the point is, let's not be like King Lear, okay? So whenever we have a case, which is, and all of us do this. I'm not sharing anything earth-shaking here. Show to someone else. Like I said, call your spouse. He or she knows how wrong we can all be, and will have no hesitation in reminding us. Just pick up the phone and say, honey, I'm thinking of calling it Nevis. And she say, well, are you sure, you forgot to pick up the milk yesterday, or something like that. So just come down to earth and surround yourself with no men, people who don't agree with you necessarily. Show to someone who disagrees with you. The Vatican has a nice principle. They call it the devil's advocate. Anytime they are taking a particular course of action, they have a person who argues the opposite side. He's the devil's advocate. He wants to make sure that that the correct decision is made, but for the right reasons. It's not just because everybody's saying, just because the Pope says that this is the right thing to do doesn't make it right. They actually have a person out there who will argue the opposite case, and that is the devil's advocate. So it's good to have that kind of a setting in your own head. Now, what could be wrong with my diagnosis? Can you see the other side of the diagnosis? And many companies have someone who tears apart cherished points of view. They actually have people like the jester, the court jester that they used to have in medieval times. This would be the fool in the court who would make fun of what the king has said. The idea was that, you know, we don't fall for our own propaganda, we don't fall for how brilliant we are, and we are able to keep some humility when we are faced with a challenging diagnosis. So don't be like King Lear. That's the first thing. Next thing is the joy of sections. Do sections, multiple sections. I once had to cut 17 levels before I came to the diagnosis. Admittedly, this is an extreme case, and I did it because the dermatologist who sent me the case is an excellent dermatologist, and I knew she couldn't be wrong. So I kept cutting levels till I found the diagnosis. Here's an example of where the sections are very, very helpful. This is a lesion from the neck of a 50-year-old female, okay, and sorry, 50-year-old male. I'm sorry, and this thing looks little odd, okay. The person who sent it to me thought that this was a squamous cell carcinoma in situ. It just looked a little funny, so I kept cutting sections, okay. So this is another section, okay. It just looks a little strange, okay. And I have seen this particular phenomenon in other cases after that, okay. So when you see this kind of this particular look, okay, and you can kind of get a sense. If you look here, you look there, okay, and now look at the next section. This is actually a molluscum contagiosum, okay, something really not diagnostically challenging, but if you don't cut into the tissue, then you see that particular appearance. Like I said, I've seen other cases of molluscum contagiosum that had that similar look, but then because of my experience with this particular case, I have done levels and found the molluscum. Maybe some of you have seen something similar. Other strategies: wash your hands. Now, this may seem like a silly thing, but let's look at what the rationale behind this strategy is. This is again from Macbeth. Okay, after Macbeth and Lady Macbeth are a bunch of really awful people who go around murdering a bunch of people, and then they feel bad, which is only understandable. So in one scene, I can't remember if it was Macbeth or Lady Macbeth. I think it was Lady Macbeth who says, all the perfumes of Arabia will not sweeten this little hand, because she could smell blood on it, you know, because it was psychologically, she was affected by all the terrible crimes that she had committed. And in fact, there was a paper in Science, okay, washing away sins, threatened morality and physical cleansing. Basically, these people showed that if you wash your hands, then you feel less guilty, okay. So you know, the guilt is, you know, when you wash your hands, you feel like you are a little more secure. So should we, when a case gets tough, should we get up and wash our hands? I've tried it, and I have to confess that I have not had tremendous results with this particular strategy. Okay, I think this is probably works in certain social domains, but it probably may or may not work in our particular arena. But this might. Can a snack be helpful? And here we have a very famous study of the Israeli Parole Board. Okay, this study, and a very famous study indeed, basically studied what happened when Arabs and Jews went before an Israeli parole board. And there were some prisoners who went before the parole board before lunch, and some prisoners who went to the parole board after lunch. And regardless of the Arab-Jew factor, before lunch, there was a higher incidence of rejection of parole. So in other words, the judges, when they were hungry and hadn't had a meal, they were more likely to be harsh on the petitioners for parole. After a snack, after lunch, and after the afternoon tea time, the appeals were more likely to be accepted. And this is fascinating. So are we making more? I have noticed that when I'm hungry, for example, I tend to see more atypia in melanocytic lesions. That's a fact. Sometimes when I'm nicely sated after a nice meal, not too much, not enough to make you sleepy. If you have had a nice, you know, Laszlo. I always think of Laszlo when he introduced me to an absolutely remarkable dessert at a restaurant, and I forget the name of it. It's one of the finest desserts I've had. Maybe Laszlo will remember and remind us of the name of it. But you know, if you have something to make you feel better, then you might be a little more objective and may not be likely to overcall things. So I think it may be a snack actually might be helpful. Of course, we also know that the brain works on glucose. So if you're running low on glucose, then it might be helpful to have a little bit of a snack. And this is just to show you, and this is an unsavory snack, of course, but this is basically there was a meeting held in Brussels where they emphasized that by the year 2050, I think we will run out of meat, and then we may have to eat alternative items, and this is a locust. Okay, and so this was like a demonstration in Brussels of the other things we might have to eat. Hopefully, we'll never have to eat locusts before we sign out. I'll probably have retired by then, but this kind of emphasizes the point about having a snack. And this is a scene of, about this Oliver Twist requesting some food from the orphanage. So the point is, don't snack out in anticipation, expectation, or rabid desire for food. Eat first if necessary. Don't eat so much that you feel sleepy, but eat enough just to keep you going. Now, here's the next thing, and this is another important study which came out. What happens when you're faced with a case that is too difficult? Okay, so here is how to be a whirling dermatopathologist. In this study, students were asked to rearrange either very difficult words like whirl or easy words such as lemon. Now you can try very hard, but whirl cannot be rearranged into another English word. Okay, but lemon can easily be made into melon, right? The point of this study was that students they were then presented with another word, cinerama, which is basically American. Okay, rearranged. Those kids who had rearranged lemon found it easy to rearrange cinerama, but those who had been asked to rearrange whirl found it very hard to rearrange cinerama. In other words, if you come upon a difficult situation, a subsequent easy situation might also become difficult. So the importance in our sign out routines is obvious. You know, if you're faced with a difficult case, should you just put that to the side immediately and just look at the other easy stuff, because you'll probably have like 90%, 95% easy stuff, 5% difficult stuff. So you can do the 95% of the stuff and then focus maybe after a nice dessert of some sort, you know, peanuts or you know, a fruit bar or something. So don't waste time on difficult cases. Do the easy ones first, build confidence, move on. Okay. At least that's what I do. The next strategy is to be like Goldoskis' pupil. So there was a famous musician by the name Boris Goldoski, and he had a piano student who played a particular piece of music incorrectly, except that he had played it exactly the way it was written. So basically what was happening was that every piece of music of this particular Brahms piano piece, which was published till that time, had that error in it. And this novice, he played the notes exactly as they were printed. When experts were playing that piece, they unconsciously corrected the mistake that was on the printed sheet. So they were almost ignoring the mistake. But it took this student who was starting out to play the piano to catch the error in every single printed copy of Brahms's music at that time on this particular piece. Once that error was caught, okay, then the music was corrected, and then the corrected copies were printed after that time. So this is known as Goldoskis' error, and it's an actual error. It's Goldoskis' error. It requires somebody who's looking at something with fresh eyes to catch the mistake. And I'll give you an example of this. And that's basically the Goldoskis' error, which I've just mentioned to you. So this is an example of a case of cutaneous toxoplasmosis. And this is an individual who had HIV, and he had a toxoplasma, and here are the toxoplasma in the epidermis and inside a vessel in the dermis. And when I saw it, I thought that I was looking at a fungus. My fellow thought it was toxoplasma, and he was right. We did the antibody. It was positive for toxoplasma, and unfortunately, the patient died maybe a week or two later, and his brain was full of toxoplasma. And this was basically toxoplasmosis. Okay, and it was something which I didn't catch, but it was my fellow at the time. He pointed it out to me and said that I was wrong, and he was right. So the point of all this is that, you know, as we are signing out cases on a day-to-day basis, I think we ought to remember when we were wrong and why we were wrong. Like in this scene, he's throwing snacks to in the water, and he comes back and he says, "We're going to need a bigger boat." So he realized that what the boat that they had was not going to be sufficient to capture this shark. And sometimes, there are certain cases. I know, for example, when I was a resident in pathology, one of my biggest problems was catching those subtle granulomas in Crohn's disease in the GI biopsies. So anytime I saw a GI biopsy in Crohn's, or had even the slightest suspicion that I might be looking for that, then I slowed down and I paid attention to what I was looking for. So remember when you were wrong and why you were wrong. Avoid the seductive bad idea. Here's a nice quote from Sean Connery. There's a group for men in Hollywood called Divorce Anonymous. If anyone starts to feel the urge to divorce, they send over an accountant to talk him out of it. So just think about the diagnosis you're about to make, and you might be in a hurry. You want to finish the case, but do not be fooled. If you make a mistake, the consequences can be quite bad. And if you wait a little, the idea may not seem that so hot anymore. Like Jack Nicholson said, marriage in Hollywood is like a nice hot bath. It's just not that hot anymore. It cools off after a short while. For example, you come the next day. If you have the capability, we've signed out 98% of your cases, and you've got 2% of cases, maybe one case out of all the ones that you've seen that you can sign out today. Sit on it, come back the next morning, look at it with fresh eyes. It might not be what you thought the previous day. Will your diagnosis stand the test of time? Change your diagnosis if you have to before you sign out. I had to change the diagnosis of that squamous cell carcinoma after I had made it to leishmaniasis. Okay, and of course, when we make a mistake, the patient suffers, and nobody wants that. Okay. Also, somebody's got to pay for that mistake, and that somebody is, as Humphrey Bogart would say, we are the ones holding the bag. So this is a famous line. Here's looking at you, kid, from Casablanca, one of the most famous movies ever made. And basically, we have to be very aware of the situation we're in. I don't have to remind you about the monetary consequences, of course. We're not like Arnold Schwarzenegger, because here's what he said once: money doesn't make you happy. I have $50 million, and I was just as happy as when I had $48 million. So obviously for him, $2 million doesn't mean that much, but I guarantee you that if I had $2 million right now, I would be more than I have. I would be quite pleased with the outcome. And money does matter, unfortunately. It's not nice to put it in these crass terms, but everybody suffers if we are not cautious with ourselves and remember that we are human beings and we can make mistakes. So we shouldn't be overconfident in our reports. We should accept and highlight any uncertainty that we have. Should our pathology reports have a disclaimer of some sort? Okay. Dr. Rosai, for example, says we should give diagnoses as percentages. I think there's an 80% chance that this is a nevus, but I have a 20% uncertainty that this might not be a nevus, something like that. I'm sure you'll get plenty of nasty phone calls. I don't recommend that. But I mean, the point is that we need to really think about what we're doing as a group. Because remember, these lawyers are going to get you in the end. Okay. So we have to educate ourselves, we have to educate our clinicians, our patients, and lawyers as well. That pathology is an art as much as it is a science, that it is practiced by human beings. Okay, humans are not perfect. Here is an example of a disclaimer. If you ever see any legal advertisements, you will see that they always have a little tiny disclaimer at the end. And we might say, no representation is being made that our diagnosis is infallible. Another pathologist may reach a totally different diagnosis. We are, I think, shooting ourselves in the foot, I think, by being very dogmatic about our diagnoses. I think we ought to be in situation, of course, if it's a nevus, it's an intradermal nevus, seborrheic keratosis, I'm not talking about those. But in cases where there is any uncertainty, I think we should let the clinician know, we should let the patient know, we should let everybody know. And if we have a disclaimer, I think it'll probably be to our benefit. Now, I don't put disclaimers in my reports, but I think this is something which we as a group need to consider, to perhaps try to see if it makes sense. I'm just throwing it out for your consideration. Remember, we are pathologists, okay, not prophets. Okay, here is Charlton Heston playing Moses, and he's parted the Red Sea over here. We can't do that. We make mistakes. Okay. This is Elvis. For those of you, they always used to say, Elvis has left the building. Well, we haven't. We are still here. We are still signing out cases. We still have work to do. So we need to figure out how to do it well, and be aware of the pitfalls and the errors to which we are prone. Some prones are general errors that most human beings make. Some are things which you or I might make. So we just have to be aware of where we are making. Just have to analyze our own performance and then work with it. So in conclusion, be sad, seek bottoms, seek history, keep an eye out for the puffy shirt, and accept the fact. I think this last one is very important. Accept the fact that we are all human and deal with it. Which brings me to the end of this talk. Thank you very much.
Hafeez, thank you so much. I mean, I think I was not mistaken when I said that you will give us a very entertaining talk. I think that this talk was probably, for those people who are just about to start their sign outs, like, getting out of fellowships or doing some work part-time, or working as dermatologists and signing out their own cases. I think that it was an excellent collection of ideas how not to make mistakes, how to be more safe, and how to be on lookout. So with that, I would like to ask the audience if you have questions to Dr. Diwan. You can type your questions into the into the chat window. In the meantime, I would like to ask you, that how, I mean, this is the what you put together in this very entertaining format. How did you get to those articles? It's really kind of, because I do have, some of the things that you are mentioning, the puffy shirt and things like that. We have all those fears and those feelings, but uh, how did you go actively to this field and be on the lookout for papers in the psychiatric literature that is supporting this? I'm just kind of curious how you started to work on this.
So, there are lots of, basically from the popular literature on the subject. For example, I showed you the books there, Why We Make Mistakes and so forth. Then there are lots of nice books by Dan Ariely, for example. There's a lot of literature out there on making mistakes, and be how, the kind of errors which we human beings make. Okay. And those books usually have nice references. Okay. They're written by, like, Dan Ariely, for example. He's, I think, a professor at Duke, if I'm not mistaken. So they usually have a nice references at the end, where they actually quote the papers, and so that you can look at those papers. So I got many of those references from there. And once you start looking at references, then you find other references, this kind of link. They just kind of go like a chain leading from one to the next. And there are other books which I showed you. You Are Not So Smart, for example. He has, like, I think in his book he has got like 50 different biases or errors which people can make, and several of them are very relevant to people like us. So, and again, that book also shows nice, has a nice bibliography, so you can pull up the original papers on the topic. I think I got the Israeli parole board study from there, for example, I think. But basically, popular psychology on the subject of errors, and is where I started, and then that led me to the references.
The information. Okay, so I would like to. Okay, it is 5 o'clock.